Hello and welcome at SmartEducation. My name is Stan. I am co-founder at SmartEducation. And actually, at this moment, I am still quite excited about what just happened. We just finished a webinar together with Professor Jill Cook. During 1 hour, she did a Q&A with us, and with a lot of physios attending live. We did a Q&A on tendons and tendinopathy. It turned out to be a very interesting talk with a lot of clinical pearls and insights that Jill was very happy to share with us. So we were honored and very glad that she took the time to share all of her knowledge with us. And now, once again, we're happy to share that knowledge with you. So here is the webinar, the Q&A webinar we did with Jill Cook about tendons. Enjoy listening.
Thank you so much. Thank you, Stein and Robbie, for asking me. I've prepared 15 minutes or maybe 15 minutes on some clinical points because it's really important to remember that not only do we do research in tendons, but we actually see patients with tendon pain. And many of the people we see have long-term tendon pain. They've seen a lot of physios and doctors. They've had a lot of images taken of their tendon and they're still not better. So I thought what I would do is pull out 2 or 3 key messages for what we see in the patients who just aren't responding to your standard physio or your standard approach to treating tendons. Really important to remember that our expertise, my expertise, our research is in lower limb tendons, and I'm happy to talk through how it might apply to the upper limb, but remembering that what I say in the next few minutes is really about our classic lower limb tendons. So we're talking about the Achilles, the patella, the hip abductors, and the hamstring tendons in particular. So my first problem that I see in the clinic is at least 50% of people who present to us with long-term tendon pain actually don't have tendon pain. And they've been managed with exercises and isometrics and eccentrics and all the things that should be helping tendon pain. And the reason that they're not getting any better is basically because they don't have pain from the tendon. And that comes down to facile, easy clinical practice where you don't spend the time to really make sure that you've got your diagnosis correct. And it comes very much back to the medical model where the 2 key things that are considered to be the points that give you a diagnosis of tendon pain is abnormality on imaging. So they've had an ultrasound or an MRI, and that's abnormal. And then you poke the tendon with your fingers and it hurts them. And so imaging abnormality, palpation, soreness, therefore I have a diagnosis of tendon pain. Now, what we know, both from some research that we're doing currently, but isn't yet published, but will be in the next little while, is that neither of those diagnoses, neither of those modalities or none of those diagnostic criteria can tell you if you have tendon pain. And there's reasons for that. The first thing is that imaging abnormality exists in tendons that are not painful. So if I took an ultrasound to all of your Achilles tendons as you were watching this webinar, we would find a lot of pathology in people who've never had pain. So when somebody presents to you and the imaging is abnormal, you can't assume the pain is from the tendon. It might be, but there's a very good chance it might be another structure that's actually giving you the pain. So that's the first thing that you have to place in your clinical practice. And the more we get into our clinical practice, the more we realise that imaging doesn't help us very much in terms of being able to diagnose that the tendon is the source of the pain. It certainly can't prognose. You can't look at an image and say whether that person is going to get better or not, whether you are going to be successful in your treatment. So it doesn't prognose either. And it's not a very good outcome measure. So if you feel that somebody's getting better or not getting better and you take another picture, it's likely to look exactly the same. So imaging lets us down in so many ways. So I would advocate and strongly suggest that you are not dependent on your imaging in any way for determining what the source of the pain is and how that patient's going to do in the long run. The second part of differential diagnosis, of course, is palpation soreness. Now, I'm going to use the knee as the example of this, in that there is research to show that the patellar tendon is the sorest point of palpation for people with OA knee and people with patellofemoral joint pain. So if our differential diagnosis, which is usually patellofemoral pain and occasionally pathology within the knee joint ourselves, and we palpate the patellar tendon and it's sore to touch, that still doesn't tell us the tendon is the source of pain. And so that immediately gives you some very good clinical clues that you have to be careful in how you rule in or diagnose somebody with tendon pain. So the two things that we use, and I've talked a lot about these, so you've probably heard some of them before, is there are two things that you must have if you are to have a diagnosis of tendon pain. The first one is localized pain. And when we talk localized, we talk one or two fingers, so the person can point with a single finger to the point of pain that stays localized with load. So very often what we see in patients is they might point to a single point in their tendon, and this is very true of the patellar tendon. They'll point to the inferior pole of their tendon, inferior pole of the patella, where their tendon attaches, and say, this is where I feel the pain. And then we say, is that where your pain stays when you jump or change direction? And very often the response is, oh no, when I put load on it, it goes around the knee or up and down the knee, or it changes where you feel it. So it's localized pain that stays localized. And the second thing is it must be a load-dependent increase in pain. So as we increase the load on the tendon, the pain should go up. So I often use the Achilles as the example of this, where we progressively load the tendon, and we know that slow load is low load and fast load and energy storage loads are high load for a tendon. So the lowest load that we can place on the Achilles tendon is doing calf raises. I don't think that's very helpful, so I'm going to stop doing that. Doing double leg calf raises and rating their pain and where it is. So where is your pain? What is it out of 10? We'd be expecting it to be localized in 1 out of 10 perhaps, or maybe even none. Then we would do a slow single leg calf raise. Where is your pain? How much pain do you have? It's likely or expected the pain will stay localized but increase. Then we will do a double leg jump, so increasing the speed on the tendon, so keeping heels off the ground and taking the load through the Achilles tendon on 2 legs. We would expect the pain to stay localized and for the pain to increase. So it might go to 3 or 4 out of 10. And then, of course, single leg hopping, where we would expect the pain to increase even more. And then we will do big hops. So really, in an athletic person, ask them to do quite large hops and see if the pain goes up. So what you would expect is for this incremental increase in pain with that type of loading program. And, of course, each tendon has a different loading profile and different loading strategies to increase the load on the tendon. If your pain is staying the same, if your pain is not staying localized, then start immediately to think about a differential diagnosis. Now, of course, we're talking here about the objective part of the examination, but there should be many things in the subjective part of the examination, the history that you've taken, that would have given you a very good clue that the person may or may not have tendon pain. But objectively, they are the two strategies that we use to determine that somebody has tendon pain. So that's the first thing that we see that goes wrong very much in people with tendon pain. The second thing that we see is that many people who do have tendon pain, or don't actually, it doesn't really matter, have been to physios, have been to medical practitioners, have been given exercise programs. The issue that we have is the type of exercise, the amount of exercise, the load on the tendon, the load on the muscle, on the kinetic chain is too low. So what we see inherently in clinical practice is that people are frightened to load the tendon, they're frightened to load the limb, They're frightened to load many conditions. And so we see people who have been given very low weights or elastic resistance, so TheraBand type of resistance, body weight exercises. Now, these are all okay in some very, very disabled and very, very low load people, so very older people or people who've been very unloaded for a long period of time. But for a person who wants to jog or play a sport or walk long distances, these types of loads are not going to be enough to rehabilitate them back to the level that they need. And I would advocate so strongly that you think carefully, not just for tendons, but for many other conditions we see. So OA knee, OA osteoarthritis of any joint, but muscle injuries and all sorts of things, that we get away from exercises that don't induce sufficient adaptation in the tissues that you're trying to fix. Now, for tendons, we see it in very young people, we see it in very old people. For most people, we would tend to have a gym-based rehabilitation. For an older person who just wants to walk the dog or play golf, where the load on the tendon is not very high, we can get by with bodyweight loads and home-based exercises. But for a good number of our patients, we have to have external weights, and we have to have heavy external weights. And we really advocate for isolated, open kinetic chain exercises. And I know that's going to knock half of you off your chair with surprise. We certainly, there's a place for functional exercise, there's a place for closed kinetic chain exercise, but there's also a place for heavy open kinetic chain exercises, particularly in the rehabilitation of tendons. So, I'm sure there will be some questions on that, and we can expand on that as you need. So please think carefully about the loads. You first think carefully about your diagnosis. Second, think carefully about the loads. Really question the person about what loads they've done and what effect that's had on their pain. That'll give you a good idea if the load has been too much. It'll give you a good idea if, in fact, it is tendon pain, because tendon pain tends to get better the heavier the load that you place on it. So that gives you some good sort of clinical tips to managing these patients. The third thing that I wanted to talk about briefly, because I'm already running out of time, I can talk very easily about tendons for a long time, is something that we often miss getting to in some of these Q&A, which is the passive interventions. So two types of passive interventions I'm thinking about is the sort of clinical physiotherapy type of interventions, the massage, the frictions, the machinery, all of those sorts of things, shockwave therapy. And then the more medically directed passive interventions, the injectables, so the PRP, the cell-based stuff, the high-volume injections. And I really want to make a simple message to show you where these fit. I have no problems with people using passive interventions as long as it's not the central part of what you're doing. The central part of what you need to do to treat somebody with tendon pain is restore function, restore strength, restore capacity in the tendon, the muscle, kinetic chain, and the brain, so that person can do the activity they want to. So as you can imagine, when we see people who've had long-term tendon pain, particularly, they're dysfunctional. They find it very hard to do very simple things like hop and change direction and raise their body weight and all of those sorts of things, because they're weak in their muscles, their tendons are mechanically compromised, their kinetic chain is compromised. If you have somebody like that and they want to be a jogging athlete, a running athlete, clearly there's a big discrepancy between the load that the tendon can take and what the load that the tendon needs to take. What I want to say in terms of passive interventions is none of those will change the capacity of the tendon, the muscle, the kinetic chain, and the brain. The only thing that will make that person more tolerant to load is, in fact, active interventions, exercise-based interventions. And this is really, really important you explain it to your patients, because very often they're frightened of load, they've been told their imaging is terrible, they've been told to rest and ice, they've been told it's inflammatory. All of the things that make these people frightened of loading, you come along and you say, hey, let's go, let's get some loading on this tendon. And you have to explain to them why, and why passive interventions are not going to take them from really poor strength up to a good strength that allows them to be functional and return to their sport. So Stein, that might be enough. I think I've used my time sufficiently to talk about that. So if you want to move on to questions, that'd be great.
Okay, Jill, thank you very much. Who am I to tell you to stop talking? I think I could listen for 1 hour straight or even longer to hear you talk about tendons. If I may, I can maybe summarize what you just wanted to get across. First of all, get your diagnosis right.
Yes.
Is it really the tendon? Then load it enough. Don't be afraid of loading.
Yes.
And third one is passive interventions alone won't do the trick. Something like that.
Perfect.
Okay. I just passed my exam here. So yes, let's move on to questions. As I said, we had some questions coming in from different people. And first of all, I would want to invite Andy and Van Tolhuizen, who did send a question. I'll give him voice immediately, and he will be able to ask the question. Andy?
Yes, hello. Hello, everyone. Can you hear me?
Yes. Perfectly.
Right. I have some questions concerning a specific topic, Speckle tracking for imaging the tendon quality. Can you maybe tell us what it is, what Speckle tracking is, if it is already in use, if it is reliable, and how we as physios can use it in clinical practice?
Yes. So when we talked originally about how imaging doesn't help us, there has been a lot of progress in terms of imaging tendons. So there's now elastography, there's UTC. Speckle tracking has been around for a little while. I think it's probably getting much, much better now. And I'm probably not the expert to absolutely tell you absolutely that it's good, bad, or indifferent. But two things I will say. I think it's a really important tool for us to improve our understanding of what's happening in the tendon in terms of the mechanical properties, the energy storage and release. All of those things will be helped by intratendinous measuring. So up till recently, we've only been able to measure gross things in the tendon, the dimensions, the hypoechogenicity. We haven't really been able to quantify it. UTC allowed us to quantify it a little bit better, and speckle tracking, I think, will be very good for us to improve our understanding of the mechanical properties of the tendon. What does it do for us clinically? The answer is it doesn't really matter how we interpret tendon imaging. It doesn't help us clinically because of a real disconnect between the imaging appearance and pain, the imaging appearance and prognosis, the imaging appearance and outcomes, basically. So to give an example of looking inside the tendon, so we've done research where we've looked at imaging and does it predict symptoms? Is there anything in what we see in the tendon that will allow us to tell us how the person is and how they're going to get better? Sean Docking did some fantastic work a couple of years ago where he used UTC that allows us to quantify tendon structure, to actually look at intratendinous structure. And he looked at football players before a season and through a season to see if anything in intratendinous measurements would allow us to look at the risk of injury, risk of pain, not injury, risk of pain. And the answer is no. It didn't matter how we looked at the tendon. There was nothing that was able to tell us that the tendon was going to become symptomatic, and again, because of this disconnect between imaging, appearance, pathology, and pain. So I think there's a place for it. I think it's in research at this point. I think it's a long way away from giving us clinically anything that's going to help us as clinicians. And I apologise for not being an expert in this area.
Okay, thank you for this very clear answer. I think we can say that Andy is quite happy with that answer. Andy?
Yes, thanks a lot. It was a very clear answer. So thanks.
Thank you.
Thank you for your question, Andy. Maybe to head off to another question from me then, when it concerns, because a lot of questions, Jill, were about management, of course.
Yes.
But when it comes to diagnosis, we all know your continuum model. How important is it? And maybe this is a good one to give away with for everybody. How important is it to get your diagnosis right on reactive tendinopathy rather than tendon disrepair? And subsequently, how can we really try to be sure about where we are exactly on the continuum model? Do you have any ideas on that?
Yes, I certainly do. And I think the good thing, again, is that we can do it clinically. So really the most common presentation is that combined state of reactive on degenerative tendinopathy, tendon pathology, where there's an area of degeneration in the tendon and that person has overloaded and they get a reactive change in the normal part of the tendon. So that's by far our most common presentation. So you can pick that up clinically. It will tend to be an older person in inverted commas, but it can be somebody in their 20s. It doesn't have to be the 40s, 50s and 60s. The person will have had a history of a grumbly tendon or perhaps pain in the other side. They may have lumpy, bumpy bits all over their tendon. So there's been some sort of history of a grumbly tendon. Now, very often the person will say, no, I don't have any symptoms at all. I've never had trouble with my tendon. And you can ask them questions. Again, you have to be subtle in your questioning and thorough in your questioning. Oh, is your Achilles tendon, has it ever been stiff when you get out of bed in the morning? Oh, yes, every couple of months I get out and my tendon is stiff. Well, that really, really tells you very clearly that person has some underlying, probably degenerative pathology, and they're presenting to you now because they have the reactive on degenerative presentation. So you can pretty much assume that everyone that you see will have that reactive on degenerative tendinopathy. The true reactive stage is very uncommon. It's by far the most common place to see that is in young horses who go out and do sprinting races when they're 2 and 3 year olds before they're actually through puberty, and their tendons will swell. So you can see a reactive tendon in somebody who is younger, because young tendons are very responsive to load and their cells are very responsive, so they tend to react very quickly. And somebody who's done something really quite strange with their tendons. So the classic example I always give is a more elite country athlete who comes into a city training program and instead of training 2 or 3 times a week, trains 2 or 3 times a day for a week, and their tendons flare up. So that tends to be a younger, acute overload sort of sensation. The whole tendon gets thick. It's very, very painful. And so you can tell reactive tendons, A, because they're uncommon, but B, because they have quite a distinct history. Pretty much everyone else you're going to see is going to be reactive on degenerative. The disrepair tendons, we tend to sort of split into the more degenerative and the more reactive. So we tend to have sort of 2 clinical subgroups. The only other part of the continuum that I talk about is a direct blow on a tendon. So I don't know if anybody has ever seen somebody who's hit their knee on a rock when they've fallen over, or banged their elbow against a door when they've walked through. That can give you, so a direct compressive blow can give you a reactive tendon. So that's the other type of presentation we see, and they are nasty. They're exactly like a reactive tendon. They're very swollen, they're very sore, they're very slow to respond, and the history is very clear, an acute overload injury of a compressive type rather than an overload type. So I think there's 2 quite distinct groups. You don't need imaging to distinguish these. You can distinguish them clinically.
Okay. Thank you, Jill. Maybe a question that can follow your approach on this is we just received that from Wout van den Berg. He wanted to know, considering paratendonitis and then looking at it more than versus Achilles tendinopathy, how is your approach on that different? What are the key differences? And then he wanted to know, I hear this is a tough one. This is a tough one.
No, it's just a long one. It's a long response. It's a very different presentation. And this is very much part of your differential diagnosis, that if you do have somebody with a peri-tendon irritation and you treat them like an Achilles, you're going to make them worse. And it's very important to be able to distinguish them. So there's a lot of things that will tell you about it being a peri-tendon presentation. The first thing is it won't be overload from the energy storage and release perspective from the springy type load. So it can be a running type injury. It's more about movement. So we get peri-tendon problems because of friction between the tendon and the surrounding structures. So this person will have done for the Achilles, a lot of dorsiflexion and plantar flexion movements without much load. So the classic that we see is somebody who's bought a new bike and they've not set it up properly. They've gone for a cycle and they've done a lot of up and down movements with their heel, and the tendon rubs against the surrounding structures and the peri-tendon gets inflamed. So the first thing you'll notice is the history is different. It's not a loading that's associated with energy storage and release. It's a loading associated with movement. So that'll give you a clue. The second thing is the pain won't be as localized. It can be much more diffuse. So it can be localized, but very often it will be up and down the tendon a little bit. It'll be in the mid-substance, but it'll be more diffuse. Okay? It won't increase as you increase the load on the tendon. So as I go from my double leg to single leg to hopping, slow to fast, the pain will stay fairly stable. It might be high. It might be 5 or 6 out of 10, but it won't get any more. It won't get greater as you load the tendon. What will happen is that any movement-related activities can make it worse. So if I get them to go up and down on their toes very high on 2 legs and that tendon rubs against the structures around it, it can be quite painful, but if they hop, it might not be as painful. So the loading profile is very different. So the history is different. Can look swollen. The pain presentation is different. The examination will give you a very different presentation as well. So you put all those things together and you can come up with a diagnosis. The other thing about peri-tendons is they don't tend to warm up. So if somebody says, look, I go for a run and it hurts and it doesn't get any better as I go on, that's often peri-tendon, whereas an Achilles tendon, for example, will warm up as you go for a run, whereas a peri-tendon will not. So there's lots and lots of things that tell you that it's different. And then the treatment is really simple. You'd stop them moving and you use some heparin-based creams, but maybe we'll leave that for another time.
Okay. You were indeed right. It is a long answer. I promise the next question will have a shorter answer. I think so. Let's try, because I know it's a question you've been having before, and I wanted to invite Jens Rosiers here on stage because he also sent us a question, and actually it's a question that you gave a 2-hour talk about when you were with us in Leuven last November. But this time I'm sure you won't need 2 hours to respond to.
You'd be surprised.
Okay, Jens, can you hear me?
Yes, I hear you.
Hi, Jens.
Hi, Jens.
Hello.
Please ask your question to Jill.
Yeah, my question is about upper limb tendons, because I think most of the research is done on the lower limb tendons. But the upper limb tendons do work in another way, I think. They have another function. So can we approach them in the same way as we do for the lower tendons?
Yes.
Thank you, Jens.
Thank you, Jens. I think for me, it's about the type of load that is placed on the tendon that helps us determine whether we can, in fact, approach them in the same way. So the question for me, if you're talking a tendinopathy, is which tendons do you use with the energy storage and release loads? So which tendons do you store energy in when you're doing activities? In the upper limb, it's pretty simple. Both our medial and lateral tendons will work as energy storage and release tendons. So if you think about playing tennis, very much you will use it similar to a lower limb tendon. The loads might be a little bit less, but the type of loading that's placed on the tendon will be exactly the same. In and around the shoulder, certainly the biceps long head, so in the shoulder is very similar to a tendon to a lower limb tendon. It's an energy storage and release tendon. It has a peri-tendon, so I can get peri-tendinopathy, but it also has compressive loads, and we haven't talked about those much. But it's very much like a lower limb tendon. The distal biceps is an uncommon injury. You often see it in weightlifters, powerlifters. That's very much an energy storage and release tendon. Where we get into key differences is in and around the rotator cuff and the shoulder. So our rotator cuff are our smaller muscles that are stabilizing muscles, and around those we have big agonist muscles. So if you think about the energy storage and release muscles at the anterior part of the shoulder, we're talking about the pec major and lats and the biceps, and they're our big muscles. So the subscap is probably protected from energy storage and release loads. Where I find it really interesting is the posterior cuff. There are no agonists for the posterior cuff. So the posterior cuff must act like a lower limb tendon. Our agonists are very much our scapula, our trunk, our lower limbs are the muscles that take the load off the posterior cuff. It's a supraspinatus that's clearly different, and that's pretty evident from all of the research that's done in the supraspinatus, and it doesn't fit the model. The other part of the upper limb that doesn't fit the model, of course, is our wrist and finger tendons. They're very much about friction. So they're very much about peri-tendon overload rather than energy storage and release and actually tendon pathology. So some tendons in the upper limb will fit the lower limb model and some won't. But of course, you have to be experienced in managing upper limb tendons, and I see a few, but I don't see a lot.
Okay, thank you very much, Jill. Thank you for answering that question. Let's move on immediately to another question. Let's talk about treatment. Let's talk about management a little bit more. We have also another specialist here in the meeting room who actually did a power talk on tendinopathy last week, Professor Dr. Stijn Bogaert. And I will let him ask you a really specific question, and I'll give him now voice. Stijn?
Yes, Stijn, can you hear me?
Hi, yes,
Stijn.
I can.
Hi, Jill. My question concerns isometric exercises. Apart from the debate on Twitter, sometimes I'm a full adept of all what isometrics can do. I've seen the analgesic effect in clinic a lot of times. But Fantastic. My question is simple in that sense. What makes isometric exercises so special? And maybe more in depth, do you think is it a mechanical effect? Is it something relating to the intratendinous deformation of the tendon? Or is it more a neural effect? Is it isometric activation in the muscle that does something neurally, peripherally, centrally? I'm interested to know.
Yes. And they're all excellent questions, and it's really easy with questions like this is fundamentally we don't know. We have some insights into aspects of it, and let's first go to the neural mechanical aspects of that. So when Ebony did her original study in the patellar tendon, she did 18 months of pilot testing, and what she found was that low loads did not help and short holds did not help. So, and what we know from the literature is low load, short hold exercises help joints, but heavy load, long hold exercises help the tendon. So it's quite possible that for two things. The first thing is that there's a mechanical conditioning of the tendon with the isometrics. So we know it takes about 5 repetitions for the tendon to reach its sort of final length, if you want to take it from that perspective. That's Richard Newsham-West and Steve Ober's work. So that a tendon has a certain length. You do 5 contractions and it does extend a little bit. We know they're viscoelastic. So about 5 contractions is about what gets us to our sort of ultimate length. Now, there may be something in that. The second thing is about heavy load in the muscle might have some big neural inputs, certainly to the muscle, but I don't know how that influences the tendon because the neural supply to the tendon is relatively limited and relatively peripheral. So I'm not sure if that is a possible effect, but, you know, you could argue that perhaps there's some sort of descending analgesia from having such a high load, so more a central effect. The third thing is Ebony's research, and this has not been repeated. There's been a lot of studies that have repeated isometrics and found variable results using variable loads and variable holds. But it was the changes in the inhibition in the cortex that Ebony found that's not ever been done since. Now, how that changes pain, we know it changes motor output, whether there's some connection centrally again to some sort of pain modulating response from allowing some lifting of the cortical inhibition, I don't know. What I really like to hear is that you have experienced or you have seen that there is an analgesic effect from heavy load isometrics. It definitely does have a place in the clinic, but the actual mechanism behind it we're not absolutely sure of.
Okay. More research needed, no problem.
More research needed. Can I say one thing? We need to repeat the cortical inhibition experiment. As I say, it's not been done because it's very hard to do that work, and it needs to be done in a different tendon. But that would be a really good start.
I'll write it down.
Good luck with your research.
Thanks a lot, Stan, and thank you for joining us here today and having some time off from clinic to share your question with us. Well, we were started to talk about treatment and management. Is it fair enough to say, Jill, that in the early stage of rehab, the starting point of rehab should be more muscle-based, and then we should move on to more tendon-based rehab later? And is that also the reason why isometrics can have a place in rehab?
Yeah. Okay. So that's another very loaded question.
Sorry about that.
That's all right. So really important, let's just put this out there, that isometrics are fabulous when people have pain. And isometrics are very good in the early stages of rehab to control someone's pain, to relieve their cortical inhibition, but they're not the treatment for tendinopathy. They're a very good buy-in for the patients. They're a very good starting point, and it allows the patient to have some control over their tendon pain. So that's the important thing. Absolutely, you go nowhere with a tendon rehab program if you're not strong in your muscle, and that the early strength, endurance is such a critical part of what we do with tendons. And one of the key things that we see in patients who present with tendon pain is very much a loss of muscle strength, a loss of muscle power. And unless you restore that, you don't have the capacity to load your tendon any higher. You need really strong, really good strength endurance so that you can move on to the energy storage and release part of tendon rehab. And if you don't spend the time in the strength and endurance part of the program, then you're not going to do well. The important thing about that is, even though it might seem mainly muscle-based, it's the one thing that changes the mechanical properties of the tendon. So isometrics and heavy, slow resistance training make the tendon stiffer, make it a stronger spring. So even though the early stage seems to be mainly muscle-based, it's actually having a massive effect on the tendon as well. And I would advocate very clearly that this is an important part to spend time in. And this is a very frustrating part for both physios and clinicians and for the patient, when you keep saying, no, you need to be stronger, you need more strength endurance, because it can take weeks for these people to get it back. But you don't go anywhere unless you get that strength first, because you need the muscle strength to be able to use the muscle as a base to do the faster loading on once you're getting to the end of, more towards the end stage of rehab.
Okay, thank you. Do you have some extra guidelines on how to progress towards more heavy, slow resistance training, and what is the perfect load, or how should we evaluate that with our patients, and how should we every time try to adjust that?
Yeah. Okay. So the issues that we have is that if you have a younger athlete, if you have a patella tendon, you need to be gym-based, as we've talked about. It's very hard to get enough load on a tendon and a muscle when you're just using body weight. If you are a recreational runner, an older person, you can do your exercises at home. But let's just look at someone who might be in the gym. So we prefer a single leg isolated exercise. So we prefer calf raises, both seated and standing, for the Achilles. We prefer leg extensions for the patella tendon. We prefer older ladies get glute med, so we won't talk about that. But for hamstring, you can do the bridging or the leg curl type exercise. So single leg and slow are really, really important in terms of starting out that program. And if you don't do that slow, heavy resistance early, then you just, as I say, you tend not to go anywhere. I was going to say something else and it's completely gone out of my mind. Can you just remind me exactly what your question was?
Well, it was about how can we evaluate
that's what it was.
Perfect,
sorry, I've already got it. Okay. So to give you an idea of how we tend to do it is that you're looking for about 25 to 30 reps as a good basis. You want to break that into smaller repetitions and more sets so that you can get the loads up. So you might do 5 sets of 6, might do 4 sets of 8, but you don't want to be up in your reps of 10, 15 or more, 2 sets of 15 being more endurance sort of base. So we tend to like smaller number of reps with a heavier load. Now, what you want to do in terms of assessing whether you've got a heavy load or not is you should be able to do your 5 sets of 6 well, but you couldn't do another set. If I said, okay, do a 6th set of 6, your muscle would say no, can't do it. So it's no good being able to sit on the leg extension machine and knock out 5 sets of 6 and at the end, go and do a dancing class or something like that. You've got to be really fatigued at the end of each muscle activity or muscle loading technique. This is why TheraBand and bodyweight exercises let us down, because you can do them and they just don't stretch you to the points that you need to be taken for a tendon rehab program. So you should get off the leg extension machine and go, I cannot do another one of these for another day or so. I'm so fatigued in my muscle. So that's how we tend to use or tend to assess whether we're getting the right sort of load on the person.
Okay, thank you. There was this other question we received from Femke here today, Femke Oudshoorn, which actually is quite similar. She was asking about adequate load for patients. Now you explained it in how many reps and how many sessions we should do. Can you say something about percentage body weight, or is this always different with a lot of, or is there... Is there a benchmark like they should be able to do this much now?
No, not really. It's really about percentage of your maximum voluntary contraction. And to do that, you have to do a 1RM test, or you have to have a Biodex, or you have to have some sort of way of quantifying it. So I think it's really hard to say what it should be. But you do, if you do it enough in the clinic or enough with the person in the gym, get very good at being able to tighter it to exactly the right amount. But you just have to get out there and have a go. And in fact, one of the things I advocate for so strongly is every physiotherapist should be doing weights in the gym, because you can't prescribe weights unless you're doing them yourself. You know the feeling, you know about fatigue, you know when you're at your maximum. So one of the ways to sort of get into that sort of stuff is to actually get in and do a gym program yourself so that you can actually teach people. But if we, for example, go to somebody with an Achilles that's older, we're not putting them in the gym. We want them to be able to lift their body weight 20 times as a basis for them to go back to walking the dog. So what we do is we assess how many times they can do it well. So we find that some people can't even do one repetition well. And I'm not joking. People are so dysfunctional. This is not uncommon. But maybe they can do 3 or 4 really well. So what we would do is get them to do 3 or 4 on one leg, 3 or 4 on the other leg. Remembering, if you strengthen the opposite leg, you get some strength gains in your affected one. Go back and do maybe 3 or 4 sets of 3 or 4 repetitions of calf raises. In that case, you stop because the quality of their movement, the quality of their muscle contraction drops off. So it's not so much about fatigue, it's just they can't do it very well. So each sort of group of people, each tendon has its own little nuances about how you assess that. But you're all good clinicians. You should all be able to assess quality of movement, fatigue, capacity to do it well. All of those things are guidelines for how you prescribe exercise in the clinic.
Okay, thank you. Continuing with management and treatment, you mentioned it in the beginning that we might be able to have to go in some depth about adjuvant therapy and modalities. Please share with us what works and what doesn't, because we always get those questions about shockwave, PRP. I can gather those questions maybe in just one answer.
Sure. Everything that you try, kinesio tape, rock tape, all the adjuncts that you use have an effect on pain. The issue for tendons is that they only have a very short-term effect and they don't change loading pain. So you can do some very fancy technique or some fancy strapping on someone and they'll get up and they'll feel better and they'll walk around and they say, oh, yes, you've really helped. You put them out to run or put them out to train and their pain will be exactly the same. So all of these strategies can be used to make somebody feel better, as long as you realise it's not going to change loading pain. The only thing that changes loading pain, as we talked about, is increasing the capacity of the tendon, the muscle, the kinetic chain, and the brain to actually take the load that you're trying to place on it. So some of them have very short-term effects, so it might only be a few minutes. Some of them can be a little bit longer. So something like shockwave therapy can last sometimes days to weeks because it knocks out the nerves around the tendon. So it can actually change your pain because of the effect it has on the nerves. Corticosteroid injections can help because they change how the cell reacts. So they calm down the cells. They stop producing nociceptive substances if that's where they come from. The key thing for me is that any adjunct that might help also can't harm. And the problem we have with many of the injection therapies is they harm and they can really change tendon structure. There's a little bit of evidence that shockwave changes tendon structure negatively. So even though it has a positive pain effect, it doesn't necessarily may not necessarily help the tendon, that very often you can see harm induced in the tendon by injecting substances into and around the tendon, and some of the other sort of Graston techniques, friction techniques. So adjuncts are great if they give you temporary relief of pain. Adjuncts cannot induce any harm in the tendon at the same time.
Okay, that's very clear. And of course, exercise-based program is still key, and then any adjuncts can help. Let me get back a little bit on diagnosis criteria. We had a question from shoulder and upper limb specialist Professor Philip Straff, who also did a power talk with us. And I know he's been busy using ultrasound imaging as well. He started to pick that up. And his question is about that exactly. Philip, are you there? Philip?
Sorry.
Oh, yeah. Yes.
I'm here.
Hi.
Yeah.
Hi, Jill. Thanks for giving us the opportunity to ask a question. Yeah, we're doing also in research a little bit with ultrasound lately, and we were wondering if you look at the tendon continuum, you have the degenerative tendon and maybe more the reactive tendon, which you talked about earlier today. And we're wondering whether that's something that you can also differentiate in with ultrasound. Maybe not. Maybe it's not the main focus, but it's all about history and then more the anamnesis. But is it also in ultrasound something that you would be able to differentiate, you think?
Yes, absolutely. They're quite distinct appearances on ultrasound. So the degenerative end of the spectrum that is a non-reparative state, something we haven't actually said to date, but it doesn't actually ever change, is the classic hypoechogenic area of tendon with high levels of vascularity in it. The whole tendon is thicker, and as you know from Sean Docking's donut and the hole paper, there's also sort of large areas of good tendon around the area of pathology. So the area of pathology is fairly indolent. It doesn't do anything. It sits there. We know if we image that repeatedly, it will look exactly the same. It gets a little bit bigger and a little bit smaller depending on proteoglycans and water content and all of those sorts of things. But it's the classic, what we would call a tendon pathology. The reactive tendon is quite different. It's no hypoechogenicity, no intra-tendinous increase in vascularity. Although it's a while since I've done it, and maybe the new ultrasounds have better Doppler or something like that. But it's a swollen tendon. It will be thicker, but the collagen fascicles will be intact, and most of the swelling appears to be between the fascicles rather than having the fascicle disruption. Hazel Screen and I wrote a paper 2 years ago now in the Journal of Applied Physiology describing what we think the pathology is in a reactive tendon and what we think's happening. And this is from her work about where the fascicles slide and rotate against each other, is that the fascicles stay intact, but you get swelling between them. That's a reactive tendon. And that's why it's reversible, because the endotendon remains intact. The swelling is from the connective tissue, is in the connective tissue and from the connective tissue cells. Therefore, it's very easy for that all to settle down. Once you disrupt the fascicular boundaries and disrupt the connective tissue around the fascicles, it becomes a more irredeemable thing, and you start to see the classic ultrasound picture.
Yeah. Okay, great. Thank you.
Pleasure.
Thank you for joining us here as well today, Philip. See you soon.
Yeah.
Then moving on, Jill, I think we've already covered a lot. I see it's almost 1 o'clock. But maybe for people who aren't familiar with a very interesting post you did a couple of years ago, 10 things not to do when treating lower limb tendon pain. There's this one thing maybe we can address before we grab lunch ourselves because we didn't eat already here. One of those things was be worried about rupturing your tendon. I see patients as well who are really afraid of when they have tendon pain. Then if we give them high loads, people react sometimes. Isn't it difficult, or isn't it dangerous for me to do this, because otherwise I'll may have a chance to rupture my tendon?
Yeah, it's a really good question, and this is such an important part of the education process that you need to give to your patients. There's 2 or 3 really important points. The first thing is Sean Docking's work, which is the donut and the hole. 80 to 90% of people who have a pathology in their tendon form extra tissue that allows the tendon to remain really strong. So a pathological tendon, or a tendon with pathology in it, isn't a weak tendon. It's very often as strong as the other side, or even stronger in terms of its capacity to tolerate load. So we often draw that for the patients, show them that even though their tendon is thick, it has plenty of good tendon structure. So that's the very first thing. The second thing is we know nothing about rupture. There is nothing that we can determine clinically or on imaging that tells us whether a tendon is going to rupture or not. So, people who've had images and it's been said to be degenerative and it's got tears and all of that sort of stuff, it's meaningless in terms of how that tendon is going to do. There is nothing that we can see on tendon imaging that allows us to predict the outcome. And rupture is one of those. So you can spend your whole life being frightened of this tendon, or you can get on and load it and see how you go. The third thing that is that the tendon will improve with progressive loading. So you want to sort of explain to the patients how if we start to load their muscle very gently, they'll get stronger and stronger, and the muscle will get bigger and bigger, and they'll be more tolerant to loads. Exactly the same thing happens in tendons, and therefore by loading them, we're going to make that tendon bigger and stronger and more tolerant to load. So the muscle analogy works very well sometimes for these people. So it's really about education. It's really about getting buy-in from the person and being confident in the message that you sell.
Okay, brilliant. Thank you very much. Jill, I have to say we feel really blessed having you here with us today. And actually, I still really hope to see you back with us in Belgium one day. I know it's not so easy for you to travel too much, but let's leave a window of opportunity there, hoping that you will come back with us one time in the future. And I'm sure a lot of people here would be interesting to hear the full story, 2-day course that you deliver, which was really, really great in November. And maybe I should say here also that we have people registering from all over the world to this Q&A today. Of course, from Belgium and the Netherlands. That's the place where we live and where we teach our courses, but even from Australia, Jill, people are tuning in. From Canada, the United States, also in Europe, Portugal, France, Germany, a lot of countries. So thank you for being with us and taking time to share with us your knowledge. If not possible in person, we could maybe do a 2-hour online course someday. We'll have to see about that. That will be a lot more difficult. So thank you everybody here also for joining. It was really a pleasure to have you with us. I do wish you all the best in your private practice, continuing working with patients. And also for you who are maybe interested in learning some more about the upper limb, because for sure Jill is more a specialist and expert when it comes to lower limb injuries and tendons. Next Thursday, we are having Joe Gibson, Jill, with us.
Fantastic.
She will deliver a power talk, so that means a 2-hour talk on the kinetic chain and shoulder rehabilitation. We're also looking forward to that. And would everybody here, from all over the world, invite to register for that. It would be really interesting to see you back again. Okay. what about wrapping it up here for today, Jill?
Thank you very much, Stein. Thanks for having me. Thanks, everyone, for your great questions.
I do think we managed to answer a lot of questions, and I hope people can continue doing their practice for the rest of the day. And for you, Jill, I wish you a very pleasant evening, because how late is it now there? It's
9 o'clock.
9 o'clock. Yeah,
yes.
Yeah. So
yes.
Thank you again, and one more last time. Hope to see you soon in person.
Thank you.
Thank you. Bye, everybody.
Bye. Bye.